Okay, so we'll talk about diffuse large B-cell lymphoma, new hope in diffuse large B-cell lymphoma. As you all know, most common, it's one of the commonest lymphomas. 30% of non-Hodgkin's lymphoma is diffuse large B-cell lymphoma. Most frequently diagnosed at older age group, 65 to 74. Unfortunately for diffuse large B-cell lymphoma, 4 out of 10 patients tend to relapse. So we want to improve on that. And the median survival of those who relapse is only 6 months. Unfortunately for people who've been in the hematology for a long time, we've seen so many treatments that try to overtake and replace R-CHOP, and they have failed over the many, many years, over the last 4 decades, and none has been able to replace R-CHOP chemotherapy. So this is a study where they looked at Pola R-CHP chemotherapy, replacing vincristine with polatuzumab versus R-CHOP, our standard. And the cell of origin was done in this study using RNA next generation sequencing. So what this study has shown is that there is a progression-free survival benefit using Pola R-CHP chemotherapy, and also there is also an EFS benefit using Pola R-CHP chemotherapy. The hazard ratio is 0.73, so there is a 27 reduction in progression using Pola R-CHP chemotherapy. Toxicity, when we replace Pola with vincristine, as you can see in this pyramid plot chart, is equivalent between the two therapies. Peripheral neuropathy, which is a side effect of polatuzumab and vincristine, has been equal between the two groups, so there is no increase in peripheral neuropathy using this treatment. Leading to dose reduction, there was no dose reduction. You can see the Pola arm, only 3.9% versus 8.2% in the R-CHOP arm, so there is less dose reduction using polatuzumab. How about efficacy? Efficacy has been measured by what treatments do the patients after they relapse, what do they receive? So there is less need for second therapies after polatuzumab R-CHP, 22% versus 30%. Radiation after Pola R-CHP was less compared to R-CHOP. Also, second line, third line was less using Pola R-CHP, and stem cell transplant was half that of those who received R-CHOP, and CAR T-cell use was also less using Pola R-CHP. The cumulative incidence of second therapies, as we've discussed, was less using Pola R-CHP, and death was equal. The number of systemic therapies was 137 versus 217. Radiation was less. If you look at the NGS type gene expression profiling, the cell of origin, the initial study was showing that ABC subtype do worse. Good risk patient age and histology. Is there psychological cost for relapse? Is there financial cost for relapse? Is the patients truly GCB, the patients we see and we call GCB in our practice? The patients we call GCB in our practice is actually done by these immunohistochemical methods. At our center, we use the Hans algorithm. But when you look at concordance with gene expression profiling, the non-GCP is 80%, the GCP is only 70%. So 30% of the patients we call GCP subtype actually are not GCP by gene expression profiling. And we have to keep this in mind. Now the area for diffuse large B-cell lymphoma is getting more and more complicated with the more and more mutations we are discovering, and simplifying things by GCB ABC subtype actually might not be so easy. So we have to think about that as well. This is a signal in GCB subtype, DZIC, which has poor prognosis, although it's classified as GCB. And you can see here they do worse, and their prognosis is worse compared to the other GCB subtypes. And you can see here in this graph, this is how they do progression-free survival using R-CHOP. Using polar R-CHIP, this is how they do, so their prognosis is improved with polar R-CHIP. Progression-free survival follow-up, this is an update, again showing persistence of improvement in polar R-CHIP compared to R-CHOP chemotherapy. All subgroups benefited from polar R-CHIP. Maybe the only group that did not benefit, subgroup, is the GCB subtype group by gene expression profiling. However, in our practice, it's very difficult to ascertain whether our patients are GCB subtype or not, because we don't do gene expression profiling, we do immunohistochemistry. So in conclusion, using polar R-CHIP treatment has shown improved progression-free survival, and it might be the new standard of therapy in the future. And thank you.